Joshi sir, can we start? Dr. Sandeep, you are muted, so we can't hear you.
Yeah, please start.
Okay, thank you, sir. Good afternoon and a very warm welcome to our NITRD CTG NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG, Sir Dr. R.P. Joshi, directors and team of NIRT and NTI, state TB officers, directors of STDCs, faculty of medical college, district TB officers, medical officers, and others. Introducing the faculty from NITRD, I am Dr. Neeta Singla. I'm Nodal Officer DRTB Center at NITRD. On my left is Dr. Saroj Meena, pulmonologist at NITRD. And joining us remotely is Dr. Rupak Singla, who is consultant at NITRD, Department of Respiratory Medicine. Sir, today's clinic is very special to us as the case is being presented and discussed by the faculty of BPS GMC Sonipat, which is a spoke to NITRD's Center of Excellence. We are also joined by the district TB officers who are currently undergoing NTP training at NITRD. We have about 30 participants, DTO participants who are attending the clinic today. And now I would request Dr. Rupak Singla to give his introductory remarks as Dr. Divan is busy with some activity at least.
Thank you, Dr. Neeta. A very good afternoon to all the participants. The DDG-TB, Dr. R.P. Joshi, Dr. Ravinder from the Ministry of Health, various WHO consultants, medical college faculty, STOs, DTOs, directors of the various national institutes, the PG students, and as you know, all of them, they joined this clinic. So this clinic has been, I feel, a great success, not only in educating the joinees, but also in the capacity building of all the medical colleges and all the STOs and DTOs, because once they join and they learn how to manage a case, and indirectly we also cover the national guidelines about the management of TB and drug-resistant TB. And it has been envisaged by the ministry as well as by our institute and the National Task Force, Dr. Bharadwaj is also there, that gradually we will try to decentralize this so that each state and union territory, they have their own clinic. And we are pleased to inform you that today, more than 29 states and union territory, they are on their own difficult to treat TB clinic. And for their hand holding, we are there, all the Center of Excellence, they are there. And it has been possible with the great support from DDG-TB, Dr. Joshi, as well as the National Task Force and State Task Force efforts. So this will go a long way in capacity building of all these peripheral institutions. And I'm sure we will keep on pursuing this activity so that the entire country is covered by this. So with these few words, I'll close my remarks. Back to Dr. Neeta, please. Thank you.
Thank you, Dr. Singla. Now I would request Dr. R.P. Joshi, sir, to give his address. Sir, your presence itself is a big motivation for us, and it shows the importance of this clinic to all the people who are joining this clinic. Over to you.
Thank you, madam. Respected Rupak Singla sir, all the faculty, all the colleagues from STDC, STOs, and other people who are part of this. So I noticed that we are nearly 200 people have joined, which is a very good sign. And it also shows the usefulness of the difficult to treat clinic. This is a very good initiative, and I congratulate the NITRD for sustaining it at an interesting level throughout and making the learning not only learning experience, but also an enjoyable experience. And it is also a capacity building for both the people who are presenting and also for our team so that they will get confidence to manage most of the cases themselves. So I'm very happy to be part of this and wish this grand success. Thank you, madam.
Thank you so much, sir. Thank you. Moving on to today's case presentation, in the current series where the states are being invited in rotation to share the difficult cases that they are facing in their own states or they have discussed in their own ECHO sessions, it will give us all an opportunity to learn from their experience. And in these sessions, we have an expert from the state and a national expert. So for today's clinic, we have state of Haryana who's presenting. And it is being presented by Dr. Sunaina Kharab. She is Assistant Professor Respiratory Medicine in BPS GMC Sonipat. State expert is Dr. Anand Agarwal, Professor and Head of the Department of Respiratory Medicine at BPS GMC Sonipat. The national expert for the day is Dr. Alpa Dalal. She is Head of Respiratory Medicine at Jupiter Hospital, Mumbai, and she is also the chairperson of Nodal DRDP Center at Sibri Hospital, Mumbai. She has more than 27 years of practicing TB and DRTB, and she has several publications to herself. So I welcome all the faculty and experts for the day and request them to start the case. Over to Dr. Sunaina for the case presentation.
Good afternoon. Thank you, ma'am. Let's start with the case. So, start with the case.
Yeah, Dr. Sunaina, please.
60-year-old male came to us in OPD from Canal in
Ramita, we can't see the slide which is being presented.
for the initiation of DRTB. So,
Yes, now it can be seen.
hello.
Yes, Dr. Sunaina, please continue.
I think Dr. Sunaina, slides are not.
Slides are not visible.
No. Yes. Now it is visible.
Okay.
You have the control of slide.
Whole slide.
Dr.
Option.
Sunaina, slide degree and it's going perfect. Please carry.
Options.
डॉक्टर सुनैना हम यहाँ से शेयर कर रहे हैं आप बोलिए स्लाइड हम यहीं से चेंज कर देंगे
Simply say next, then we'll.
आप जब भी
Hello.
हाँ डॉक्टर सुनैना
जी मैम अब आवाज आ रही है.
हाँ
Are you sharing the slide?
yeah we will share the slide.
Okay, ma'am.
हाँ डॉक्टर सुनैना can you see the slide now?
Yes, ma'am.
Can everybody see the slides?
Yes, ma'am. I am able to see.
Sure, great. हाँ आप शुरू करिए.
Next slide. So first start with the history of patient. 60-year-old male came to us in OPD with referral card from Karnal in view of DRTB treatment initiation. He is a retired security guard, Hindu by religion, and belongs to lower socioeconomic status. He was apparently normal 3 months back when he developed dry cough initially, but was associated with expectoration following 10 days after initiation of his symptoms. There was no associated postural and diurnal variation, no aggravating relieving factor, and no syncope was there. As cough was associated with sputum production after initial 10-12 days. It was around 15 to 20 ml in quantity, and which was thick in consistency, whitish, non-foul smelling in nature, with occasional blood staining was there. And there was no aggravating relieving factor associated with sputum production also. There was associated with significant loss of appetite, weight loss, generalized body ache, and night sweats. Next. And there was significant history of contact present in mother and sister. Both were tubercular positive. They took treatment for 6 months and got cured of tuberculosis. No other significant personal and allergy history present in this patient. If we talk about the treatment history, patient took ATT for 4 times in the past. First, in 2015, he was diagnosed of drug-sensitive pulmonary TB, for which he took 7 months treatment, and regime was this, and he got cured probably because he don't know whether sample was taken, but he took full course of the prescribed regime. Then again in 2016, patient developed drug-sensitive pulmonary TB, for which he took treatment for only 3 months and he defaulted after 3 months. Reason was because he felt better, there was no symptoms, so he left treatment by himself. Then after 2 to 3 years, in 2019, he was again diagnosed of pulmonary but drug-resistant tuberculosis, for which he was put on a shorter injectable regime in July 2019, and subsequent second line LPA report was sent. In second line LPA report, patient was fluoroquinolone resistant, so his regime was changed to newer drug containing a longer MDR regime from December 2019. It contained bedaquiline, kanamycin, linezolid, cycloserine, ethionamide, pyrazinamide, clofazimine. But after 3 months, he again defaulted due to roadside accident. His leg got injured, and due to which he could not visit the hospital for ATT. So he defaulted again after 3 months. Then after 4 to 5 months, he again came to us, not us, to Karnal district hospital. From there, he was diagnosed of rifampicin resistant tuberculosis, but for LP, he was sent to NITRD, where he was diagnosed of XDR. He was resistant to rifampicin, high dose isoniazid, high dose moxifloxacin, and fluoroquinolones. On extended DST, he was diagnosed of bedaquiline and ethionamide resistance also. Next. On examination, patient is conscious. Patient was conscious oriented to time place person. BMI is 19. He's moderately built, poorly nourished, afebrile to touch. All the vitals are within normal limit. There's no significant general physical examination finding. On inspection, trachea was deviated to right. On palpation, it was confirmed that trachea is deviated to right. There was apical impulse was not appreciable. Chest movements were reduced on the right side. Whole chest expansion was around 2 centimeter. AP to transverse diameter ratio is around 4:6. Vocal fremitus was decreased on the right side. Next. Next slide, please. On percussion also, there was dull note on the right side. On auscultation, decreased air entry on the right side. Bilateral V's were present. And there was bronchial breath sounds on the right side. Force creps were present on the right side, and vocal resonance was also decreased on the right side of the chest. CVS, CNS, and abdominal examinations were within normal limit. On ENT examination, there was bilateral sensorineural hearing lost. Rest was within normal limit. Next. On investigations also, like CBC, LFT, KFT, TSH, urine microscopy, all were within normal limit. On pure tone audiometry, there was a bilateral sensorineural hearing loss, and our patient also complained of tinnitus. And on ECG, QT interval was around 370. Next slide. Chest X-ray is chest X-ray, PA view. of the patient exhibiting fibrosed right lung with tracheal deviation to right, and and whole of the hemithorax is shifted to right side, so mediastinal shift is also there. Next, on CT, HRCT thorax, next, it was confirmed that there is reduction in lung volume with shifting of trachea and mediastinum towards the right side. Next. So to design the personalized XTR regime of this patient, we have to keep 2 points in the mind. Like first, we have to see sensitivity pattern of the all drugs which are available. And next is history of previous intake of all the drugs. So if we talk about group A drugs, bedaquiline, fluoroquinolones, linezolid, bedaquiline and levoflox was resistant. Only linezolid is sensitive in DST report, and all the 3 drugs were taken in the previous regimes. And group B drugs, clofazimine, cycloserine, both were sensitive and both were taken in the previous regime. If we talk about group C, it is sensitive, but it was not taken in the past regimes. Kanamycin is also sensitive, but it was taken previously, and patient is also having bilateral sensorineural hearing loss with tinnitus. Pyrazinamide, there is no sensitivity pattern available, but there is a history of previous intake. Ethionamide is resistant, and there is history of previous intake. Past ethambutol and penems sensitivity patterns are not available, but patient hasn't taken PAS and penems in the past, and he has taken ethambutol. So this is the sensitivity pattern and history of previous intake of all the drugs which are available to us. Next. So now point of discussion, how to decide an effective regime in this patient, and what other investigations can be sent for this patient before planning an effective regime, and what could be the cause of bedaquiline resistance in this patient.
Thank you, Dr. Sunena.
Yes.
That's a very interesting case, and we come across such kind of cases almost every day here at NITRD. So I'll just tell you the summary again, because almost 100 people have joined since you started the case presentation. So this is a 50-year-old male who has received multiple courses of ATT since 2015. Earlier also he has received DSTB treatment twice in 2015 and 16, followed by DRTB treatment with ejection containing shorter regime in 2019, and has failed to that regime. In 2020, patient received bedaquiline containing all oral longer regime with some modification, which he took only for 3 months and defaulted due to some leg injury, as you said. Then he has presented again in 2022 when an extended midget shows that there is resistance to bedaquiline, fluoroquinolone, INH, rifampicin, and ethionamide. So now the issue is how to design an effective regime. Patient is sensitive to linezolid, clofa, cyclodelaminid, and injectable, that is kanamycin. So before I invite Dr. Anand, who is the state expert for this case, are there any questions on the history of the patient? Yes, Dr. Rishi, you have a question?
Please unmute me.
Dr. Rishi is asking about saturation of the patient.
Madam, is there any history of any comorbidity, like diabetes, any other comorbidity present?
No comorbidities there, sir.
And is there any history of breathlessness, any SpO2 below 95 or something like that? Because right side is almost fibrosed.
All vitals are within normal limit. No history of shortness of breath.
Dr. Rishi, you could always, for benefit of the audience, could you tell us why you are asking those questions, so that we also understand what all to see?
Yeah, madam, because on the right side, on the X-ray, we are seeing there is a deviation of the trachea also, and there is also the sounds, the percussion sounds, as well as the apical auscultation sounds are also less, and the chest diameter is also expansion is reduced. So there are chances that patient might be having fibrosis. So in that case, their patient might be having the signs of breathlessness, And since patient is having such a long history of 5 years, almost 6 years, so it is also necessary to know to exclude whether the patient is diabetic or not. HIV is known as HIV diabetes because these are the comorbidity which are associated more with this treatment, and because of this, the treatment is often gets delayed. So we had also see the assessment of diabetes and other comorbidities also. This is the main question.
Thank
That
you.
was asked.
Thank you, sir. Dr. Bharadwaj sir wants to ask a question.
Nita, I want to ask one question. I query from DTO Karnal. So when the patient got accident, why the patient was not placed? He was put on a longer regimen. So why the patient was not placed? Because he took medicine for 3 months only. The patient could very well, if he was not able to come to the hospital, the patient should have been traced at the home. So this is my query from DTO Karnal. Thank you.
Dr. Sunaina, you have any information on whether efforts were made to retrieve the patient when he defaulted?
No, ma'am. Patient was not contacted by any of the worker from nearby area to continue the regime.
So I had few questions, Dr. Alpaya. So first 2 times when he took drug sensitive TB, that time the gene expert test and it was documented to be a drug sensitive disease.
No, ma'am. We don't have any document regarding his CBNet or other tests.
Yes. So we don't know that whether it was drug resistance right from the beginning, or those 2 episodes which are apparently treated as drug sensitive could have been very well drug resistant disease even then.
Yes, ma'am, sure, because we don't have any document regarding those.
And when the third episode was treated as MDR, so obviously that time gene expert would have been there. So do we have LPA report then whether FQ resistance was ruled out during the 3rd episode of
that we have that
Yes.
fluoroquine resistance report we have with us.
So that time it was not fluoroquinolone resistant.
Sorry, ma'am, I'm not able to hear.
So 3rd episode of TB, when he was treated with shorter regimen, that time do we have documented LPA reports showing that patient did not have FQ resistance? It was purely
Patient
MDR.
was started on a shorter regime. After that, second line LPA report was sent. And in that report, he was resistant to fluoroquinolone. So regime was changed from shorter injectable to longer. At the time of initiation, we didn't have any report of sensitivity pattern of fluoroquinolone.
Okay, it took quite some time to get the report and change the regimen because he was taking for some 3 months.
It took around for 6 months.
So it took 6 months for us to get the report
To get that report. Yes, ma'am.
FQ resistant and change from shorter regimen to longer regimen. So by then he had already continuing the ineffective regimen.
Yes.
Dr. Jaikishan sir has a question.
So after 6 months, we change over to all oral longer regimen, which again he defaulted after 3 months.
Can I come in, Alpha?
Yeah.
Can I come in? I'm Dr. Munje.
Hello.
Hello. Hello. If you look at the chart shown by Sunaina, it just says that regimen changed after second line LPA report, right? But it does not mention what was the second line LPA report because patient has taken injectable in the first regime, the second time when he was treated with retreatment regime, as well as what was that? L. So we don't have a documented second line report, one thing. Secondly, if you look at the left column, Dr. Sunaina, this treatment was given for hardly a year or so. The treatment was stopped. आपका left column ऐसा बोल रहा है that the treatment was from July to December 2019. And after that 6 months of treatment of shorter injectable base, patient को यहाँ भी injectable मिला है, right? So we need to know whether again करना चाहिए था इसका, and say we need to know whether there is resistance to injectable. Because आप आगे जाके देखोगे तो patient received 2 years, nearly 2 years treatment of newer drug containing longer MDR regime.
Ma'am, he didn't, sorry to interrupt, but after second line sensitive, second line LP report, he just took treatment for 3 months and he defaulted.
But default makes it more likely, na? After 3 months, it's not less, no, 4 weeks, 6 weeks. Nahi hai. See, what I'm trying to say is that probably he must have developed resistance to injectable by this time, and still we have given him kanamycin in December, ka jo longer MDR regime hai, right?
I think, ma'am, what the table which madam has just shown Dr. Sunaina, their patient is sensitive to injectable.
Yes.
He's still, the patient is still.
Patient is sensitive to injectable, second line injectable drugs.
We have another report in 22 when he presented again after default, and that is showing that he is still sensitive to kanamycin and amikacin.
Yeah. So taking your point further, Dr. Alpa and Dr. Radha, that we know there are gaps in DST which should have been done in time. So that point is noted. Now, I think Dr. Jaikishan has been asking a question. He's raised his hand. Dr. Jaikishan, sir, yes, sir.
Thank you. So there are 2-3 points here. One, that the patient had contact with this mother and the sister. Whether there was history of the drug resistance in them, 1, 2, and every time he defaulting after 3 months. So whether somebody contacted her or not, whether this is a program failure or what we should say. Why a patient should be say stopping the treatment after 3 months and then landing into the say distance of the bedaquiline and the ethonamide, and now we are losing the very precious drugs. 4, the patient is having almost whole of the lung, right lung is destroyed, and the left lung is also showing the infiltrates. Whether the patient is also having the pulmonary hypertension, carpomanal or not. And then in the presence of these only few drugs left, the patient is not going to have the good response. This is a weak regimen. Whether we are thinking on the line of the referral for the lung transplant in this patient, they are my observations.
Thank you, sir. So we clearly see that there are some shortfalls at the level of field where not enough efforts were made to, do the default retrieval, or timely CB-NATs were not done. And I think this being medical college, patient only reported to medical college after it has undergone all those defaults and mismanagements. So now I would request Dr.
What was the pulmonary hypertension in this patient?
Dr. Sunaina, hypertension?
There are no signs of pulmonary hypertension at present. Patient is admitted with us right now. So.
And are you considering for the lung transplant?
No, sir, not right now. We are just focusing to patient get cured of XDR first, because he is improving.
It's unlikely.
Yes, ma'am.
So
Now
he
we
can be
have
referred.
two
He can be
questions
referred for
of us. How to treat her from PD point of view.
Okay.
Thank you so much, sir, for that questions and bringing things to our notice. Now I invite Professor Anand Agarwal, sir, who is the state expert. He's from BPS GMC Sonipat. He is the case is under him now. So over to you, your comments.
Very good afternoon.
Welcome, sir.
So actually, I have seen all the slides, whatever Dr. Sunana has discussed. This is a very interesting case actually, of having 6 years of APT history. Many times, many comes in his life. So, if we talk about the current scenario, as Dr. Sunana asked, how to decide an effective XDR regime in this patient. So, according to the guidelines, we have to choose group A, B, C, A, B, and C drugs. So, if we look at the resistance pattern, we found that group A drugs are resistant. Only one drug has left, that is linezolid. Though it has been previously utilized, but the sensitivity pattern shows uh, it is sensitive to that particular patient. So we can choose one drug, linezolid, from the group A. And group B drugs, both the drugs are sensitive, like clofazimine and we can say this cycloxamine. So both the drugs, clofazimine and cycloxamine can be added. And group C have the 7 drugs. So out of them, kanamycin can't be used, amikacin can't be used because having the sensory neural deafness. So delaminate can be chosen because it has not been utilized previously. And another drug, if you want to choose the PAS, because it was it is sensitive. Ethanamide can't be used, and the one meropenem or abipenem that we have not keep in regime because it is a quite costly drug, and the one peripheral central catheterization is also required in that case, and patient are not giving the consent also related to this long-term catheter placement. So I think the non-injectable regime with the 5 drugs as per guidelines is sufficient. So we can add one more drug, that is imipenem, but we have not chosen it. This is the last drug and this is the last resort. So we have not used it as a last resort. Second point, what other investigations can be sent? So we can say if the patient, though he's improving, but the still patient is on delaminate, and we have one drug in hand, that is imipenem. At this point, when we start the regime, we can send the whole genome sequencing or the next generation sequencing, so that we may get the idea about the resistance pattern in other left out precious drugs on which we have to put the patients. So that we can choose. I need the comment from Dr. Rupak Singla also regarding this, because this is a very this is a policy matter whether we should send the whole genome sequencing in this case or not. And the third point, what could be the cause of bedaquiline resistance in this patient? So that is very clear. There are different theories which are related to the bedaquiline resistance. So actually, the bedaquiline have 3 genes. The one is RB0678 genes, and second is ATP genes, ATPE genes, and PAPQ genes. So these 3 genes are responsible for the resistance of the bedaquiline. But if we talk about the acquired bedaquiline resistance, so there are 2 things. The first is that the minimum inhibitory concentration of the bedaquiline reached after 1 month of starting of this drug. So once if we generate a regime, it should be in such a way that first regime should have one killer drug or one potent drug that protect the bedaquiline initially for first week, like fluoroquinolones or the linezolid. If a patient is fluoroquinolone resistant initially, and it has not been checked, and we incorporate bedaquiline regime to the incorporate fluoroquinolone in bedaquiline regime, so that may be the possible reason of bedaquiline resistance. Later it comes out that the patient have fluoroquinolone resistance, and it may lead to the bedaquiline resistance also. Along with that, minimum inhibitory concentration, suppose in this case, where the patient took the treatment for 3 months and then he gets chances of bedaquiline resistance is very, very high according to the theory, because bedaquiline is too high. It is around 5.1 month, but the concentration of bedaquiline is less gradually if it will not protected by other drugs. So once the bedaquiline regime has been started and other drug has been stopped after 3 months, the chances of development of bedaquiline resistance is very, very high. So probably it may be the cause of bedaquiline resistance in this case, because the patient got defaulted after 3 months of taking of this bedaquiline regime. So I think all the points which has been raised must be correct.
Thank
So,
currently patient is on delaminate, linezolid, clofa, cyclo, and PAS. Okay, and the patient is, I think, culture negative at the moment. Dr. Alpa, what would be your comments for this case?
Yeah, so a lot of points have been covered. So now we have seen the history of this patient who has been a frequent defaulter, some past reports not being available. So we do not know whether right from the beginning this was drug-resistant TB. And in the process, almost 5 years have gone by. And in the process, we have had destruction of the right lung and formation of cavity and a fibrous lung. So very complex situation we have here. The first, when we have to design a regimen for such kind of patient, so we have to, follow the rules kind of. So drugs which patient has never taken and DST showing sensitive would be our best bet. So here, this drug is delaminate and amikacin. So we have these two drugs the patient has never taken and DST is showing sensitivity. So both drugs could have been part of the regimen, but he already has sensory neural deficit here. So we are not able to use the amikacin. Then, yeah. Secondly, drugs which are never taken and DST not available. So in this case, carbapenem, we don't have the DST available, but we assume that it should be effective, and PAS is another drug which we don't have DST, but patient has never been exposed. The third would be drugs patient has taken and DST is showing sensitivity. So we have linezolid, clofa, and cyclo there. So here the regimen would be delaminate, clofa, linezolid, cyclo, and the fifth drug is PAS. Okay. Now drugs are already taken and DST showing resistance, that is bedaquiline, fluoroquinolone has been resistant right from the beginning, and ethionamide. So those drugs we have not included in the regimen. Here what I would have done differently is that this patient right have already been defaulting so frequently, we do not know how can we really give him carbapenem for a long-term basis. So this patient has to be put in the hospital. They have to be in the hospital for a period of 6 to 9 months that we give them carbapenem. So this is what, these are called salvage regimen, which we have been using for patients who are, chronically treated, multiple treatments, and we have very few options there because this is the last chance that he has forever to get cured. So carbapenem ideally should have been added, and this patient should be hospitalized for 6 months to 9 months to give carbapenem. Now the second question is, so this is what we are talking about, is treating the microbiological part of it, making him culture negative. Now we have more complex situation at hand because his already right lung is quite destroyed and left lung is not also completely normal. But here in a patient who has been frequently defaulting and this kind of lung involvement, the chances of relapse or culture conversion after having become culture negative are pretty high. So we should consider a surgical option for him, provided he's fit enough lung-wise and general condition-wise to undergo the surgery. So, and since the whole of right lung is involved, after doing pulmonary function tests and after assessing his risk, right pneumonectomy along with the salvage regimen should be the right choice for him to have a chance of complete cure and prevent the next relapse. And so this is what is being, and apart from what Dr. Agarwal said about bedaquiline resistance, here in this case, we do not know the 3 months that he received bedaquiline also, how much was the compliance, because there has not been a proper monitoring and he's been taking treatment at home and he's been relapsing frequently. So we do not know in this case also whether he was, compliant with bedaquiline 3 months on paper that he took bedaquiline.
Thank you, Dr. Alpa. Are there any questions, Dr.?
There is one question in the chat box. Why don't you prefer pyrazinamide with ethambutol as a fifth drug? Dr. Sunaina? Dr. Anand Edward, can you answer this, sir? There's a question in the chat box that why we didn't prefer pyrazinamide or ethambutol as a fifth drug in the regimen, current regimen.
I think Dr. Anand got disconnected. Dr. Alpa, can you take that question?
Yeah. Can you repeat that? There's been a little problem with the voice quality.
Ma'am, there's a question in the chat box. They're asking that why didn't we prefer pyrazinamide or ethambutol as a fifth drug?
Yes, so pyrazinamide and ethambutol has already been used in this case, and that too twice this patient has received. So highly unlikely that these drugs are going to be effective.
Thank you, ma'am. Dr. Jaikishan sir has a question. Yes, sir.
So the patient is having bilateral extensive disease, and there are chances of the multiple infections, and whether we have gone for the testing for the sputum for fungus, sputum for the NTM, and so that we can take care of them if they are there in the patient, and that should be taken care simultaneously. The possibility of the multiple infections, infestation, OIs cannot be ruled out, and that should also be done.
Yeah, so I think culture would have shown the growth of NTM, which is not the case, and subsequently, I think we've been able to achieve culture negativity. Subsequent cultures have been negative. So I just had one question, Dr.
Fungal
Singla.
infection. Fungal infections.
Fungal infection, yeah. So patient, how is the patient doing clinically? So since we monitor the patient on 3 counts, clinical, microbiological, and radiological. Radiological improvement will not expect here much because already the right lung is destroyed. So clinically, how the patient is doing now? I think some part of the presentation is still there now, or Dr. Sunaina? So microbiologically, we've seen that last 3 cultures have been negative. Radiologically, we are not going to see much change. So how is the patient doing clinically? Has there been weight gain, tachycardia reduced, oxygen levels maintained, and nutrition, appetite, symptoms, all that? So how is the patient doing on these accounts?
Ma'am, patient is vitally stable, appetite is good, gaining weight, all the weight band is same. But he has gained 5 to 6 kgs, and there are no fresh complaints like shortness of breath or cough, increased sputum production, fever, weight, night sweats. All these symptoms have subsided. Patient gaining weight, having good appetite, and all last 3 culture reports are negative. So I think patient is improving clinically as well as microbiologically on culture reports. And radiological investigations are same like a previous. Patient is not deteriorating or having any active infection at present.
That is good. So unlikely that he would have any significant fungal infection or NTM infection. That's very unlikely because symptomatically also patient is improving. The only question would remain that would have been started in the beginning itself. So can we consider starting carbapenem at this stage? So one is if it's possible and patient is willing to get hospitalized, then we can consider adding carbapenem because this we will not call, I mean, sometimes there's a question whether we can add single drug to a failing regimen, but this is not a failing regimen because patient is improving microbiologically as well as clinically. So we can consider adding carbapenem at this stage, provided patient is willing to stay in the hospital and take the injection. And also one more thing, Dr. Singla, I would like your comment also and your thoughts on this. And whether bedaquiline sensitivity is absolutely reliable, or there is still a possibility that there can be discordance and bedaquiline could still be sensitive and we could consider, or once the DST is showing resistance, we should not consider at all.
May I come in?
Yeah, Dr.
Yes, sir.
Yeah. If you see here the case from the beginning, how the whole thing started. So patient was put on the this shorter regimen, and the second NLP report came after say 4, 5, 6 months. So and he was found to be the fluoroquinolone resistance. So in that case, he was on an inadequate regimen, and during this regimen, he must have developed. There are quite high chances in these 4, 5 months to the other drugs in the regimen, which include clofazimine, ethambutol, pyrazinamide, and the high dose INH, ethionamide, etc. And that's what we are noticing also now, that he, and subsequent to that, after having failed, or you can say failed because patient has received 5 months of the shorter regimen, and when the treating unit decided on the modified longer regimen, I find in the modified longer regimen, bedaquiline, linezolid, cycloserine were good choice, but 3 drugs, rest of the choice were the drugs where patient could have already been resistant to. So in the bargain, what must have happened, that we lost these drugs also. We lost bedaquiline, linezolid, cycloserine also because he was on again on inadequate regimen. Not only that, as Dr. Anand Agarwal also said, he stopped treatment after 3 months. So after 3 months, although he must have stopped the treatment, but bedaquiline, because of a very long the half-life, it was persisting in the blood for few months. And so practically he was on a monotherapy with bedaquiline with inadequate blood concentration. So that might have further enhanced the development of bedaquiline resistance. So keeping this factor in mind, I think plus the bedaquiline resistance report is from a national reference laboratory, that is from NITRD. Let us presume that he might be resistant to bedaquiline. Although some cases when it is not 100% reliable, bedaquiline delaminate, but from a national reference lab with this history of having taken only 3 months and then monotherapy, the chances are quite high that he is genuinely resistant to bedaquiline. Then after that, this what the new regimen has been planned for this patient. This includes delaminid and PAS, which have never been taken in the past and are sensitive also. Other drugs are linezolid, clofazimine, cycloserine. Linezolid, clofa, cyclo patient has taken in the past. Although now found to be sensitive, plus we are cornered now. We don't have much to choose the drug for this patient. Only thing, as Dr. Alpha has been saying repeatedly, is the question of adding imipinem, the PNEMs. So, because this is the last chance for the patient. In case we don't make a robust regimen now, we might lose these drugs also. But the logistic challenges with, we have given the imipinem in more than 80-90 patients. We need to insert a peripheral line, the PIC line we call it, and at 1 hour infusion in the morning, 1 hour infusion in the evening. The cost of the drug, ideally speaking, they should be hospitalized for throughout. But what we do after say initial 1 or 2 months, we discharge the patient, educate the attendant how to manage this PIC line, take of a nearby nursing home, and then they can give these infusions. So these logistic challenges are there. In case we are able to overcome them in the newer regimen with delaminid, PAS, linezolid, cycloserine, and clofazimine, it will be a very good idea to add the PNEMs like imipinem. So that might really make the regimen robust, because as of now, delaminid and PAS are the only 2 very reliable drugs. Other drugs patient has taken, although lab is saying they are sensitive. And for these drugs, the correctness of the lab in identifying the drug sensitivity pattern or resistance pattern is not 100%. It could be just 70, 80, or 90% only. There are chances that the lab is saying sensitive, but in view of the fact that patient has taken these drugs, it could be actually be resistant. So that is another thing there. Regarding the surgery, I think patient has almost destroyed lung of the right side. Left lung is also doesn't look like normal. So we have to repeat, the CT scan has been done, but not very clear in the slide. If the left lung is also involved, chances are very low that we can offer him surgery. In case we find left lung is totally normal, and then we have to perform the lung function tests, including spirometry, diffusion capacity, and see whether this patient will be able to tolerate surgery or not. But to me, it appears, looking at the X-ray and CT scan, chances are low that he is a surgical candidate. And regarding the WGS, you see, we have in this case the extended DST report from a national reference laboratory, so that we can rely upon. The advantage of, suppose in that case, suppose we do the WGS, as one of the cases are presented in the earlier meetings, and it has a different pattern. Will we be accepting that WGS report or the culture DST report from a national reference lab? That will be another issue. As of now, the central TB division, the national experts are not ready to take therapeutic decisions based on the WGS. That is what my understanding is. In case some DST is available from a national reference laboratory, phenotypic DST, better we go by that. Plus, of course, we have to see the history of drug intake by the patient. So as of now, the history of drug intake and the phenotypic DST, they are matching. Although for linezolid, clofan, cycloserine, patient has taken them, still the lab is reporting as sensitive. So we are giving that benefit of doubt to the patient, and we are giving these drugs. So the final regimen, I feel, I agree that delamanid, PAS, linezolid, clofazimine, cycloserine, they should be considered. Plus, in case possible, logistically possible, then imipinam should be added. Regarding the question of this lung transplant, I think it is too early. First, we have to treat the patient by the infection. Active infection is he's having this drug resistance TB, which is XDR, rather more than XDR. Need to tackle that and then investigate the patient whether he is a candidate for lung transplant or not, in terms of the spirometry, the diffusion capacity, oxygen saturation, presence of pulmonary artery hypertension, and other comorbid conditions. That's a different assessment altogether. And then we see whether he is a candidate for lung transplant or not. But as of now, it may be a little early. First, we have to focus on treating him for this current TB infection. So that we have to see. So again, we learn from this that we have to obtain the results of second-line LP, first-line LP as early as possible and act on this. Otherwise, we are likely to miss very important drugs in the shorter regimen. And now in the country, we are not having injection regimen. We are having bedaquiline containing regimen. So in cases who have fluoroquinolone resistance, we are going to lose bedaquiline. We are going to lose clofazimine plus the accompanying drugs. And then even the longer oral regimen becomes ineffective without the addition of drugs like delamanid, imipinam. PAS is usually not available at most of the places. So it becomes very difficult to treat such cases who fail to the shorter regimen because of FQ resistance. So it is my request to all the participants that look for the fluoroquinolone resistance whenever we are starting the shorter bedaquiline containing regimen, and act upon this as early as possible. So these are my thoughts in this case. Thank you. Back to NITRD team, Dr. Deepta.
Thank you, Dr. Singla. We have a question from Dr. Ritu Singhal and Dr. Rishi. So before Dr. Ritu, I invite you for your question. Dr. Singla, I have a question that when we are making a regime for this patient, do we consider cross resistance of bedaquiline and clofam?
Yes, especially we should consider that it could be a cross-resistant, but as of now, we don't have much choice. We are cornered. We have to choose a drug. Lab is saying clofazimine is sensitive. Phenotypic DST is saying it is sensitive. So in that case, we are giving that chance to the patient. But yes, the very good point you have raised is that the cross-resistance of bedaquiline and clofazimine should also be considered. That also depends on which mutation pattern is there, which we are not having in hand. But since phenotypic DST is saying it is sensitive, So we are giving that benefit to the patient. It's important drug, it's important sterilizing drug. So we are giving it.
Thank you.
So can I add
Yeah,
one?
Doctor, yeah, sure, Dr. Alpha.
Yeah, so that's why it's even more important to consider carbapenem at this stage, because in the current regimen, 3 of the drugs that we are using have already been used previously. And also the duration of delaminate. So, I mean, usually in the program, delaminate and bedaquiline are given for 6 months, but that also, in this patient, delaminate has to be given throughout the duration of the course. I think, and that's very important.
Yeah, that's very
Yes.
important. Dr. Sunaina, I hope you are noting that.
We are continuing the development.
Yeah, yeah. Thank you. And Dr. Ritu, you have a question?
Yeah, thank you so much. So this is just a comment to Alpa's queries and in continuation to what Dr. Singla sir was saying. So one thing is there that regarding the bedaquiline, I must emphasize the phenotypic DST for bedaquiline is fairly reliable, not just from National Reference Lab, but from any lab which has been certified by Central TB Division. That's one thing. Secondly, coming to the comment by Dr. Alpa ma'am about the WGS, the bedaquiline delaminates are the newer drugs. Still, the mutations and the significance of mutations for the newer drugs is at a very nascent stage. So we have to take it with a pinch of salt, and we may not be able to consider it well. You know, we may not consider it at this stage. So these are the 2 things that I wanted to make a comment on. Thirdly, that delaminate and bedaquiline, both of them actually are phenotypically pretty reliable. That's all I needed to say. I'm so sorry about the quality of my voice right now, and I hope it's clear.
No, you're perfectly audible. Thank you, Dr. Ritu, for your
Thank
comment.
you.
Dr.
have
Rishi,
one
you had a
question.
comment?
Yeah, sir, because since this patient is resistant to bedaquiline, are there any chances that patient might also be resistant to delaminate? And my second question is, since in the current scenario, we are on the starting verge of resistance to bedaquiline or may not be delaminate. So we also need to know the status of the carbapenems, since it is being given IV line near clavicle region for 6 months BD. So, and its cost is also too high, and we cannot procure it from the Central TB Division. So there are chances that it may also increase the catastrophic cost to the patient also. So these are my concerns.
The first one I'd like to answer. Delaminate and bedaquiline cross resistance is not there.
Too many people talking.
Yeah, ma'am.
Yeah. So about the line that for for imipenem, generally we use PICC line, this peripherally inserted central line. So it is not put in the clavicular area. I mean, it's not the central line per se. So they are much easier to manage. So we have managed patient for 6 months or sometimes 9 months also on the line. Sometimes if the line either gets infected or there is some fracture of the line, we might have to change the line, but it can be managed from the peripherally inserted catheter. That's one thing. I think there is a provision in the program also that locally imipenem can be purchased. Now, the patient is from lower socioeconomic status. He cannot purchase himself the imipenem setting. So this can be purchased locally and it has to be given. So Dr. Singla was saying that sometimes they train the relatives and ask them to take help from local sources, human resource, and then give the injection. But in this case, this patient has been so unreliable and so frequently he is defaulted. So if we have to give carbapenem, the only way would be to keep him in the hospital, peripherally inserted central line, have this injection locally purchased and manage him inpatient during this period.
And ma'am, since you have all been giving these imipenems, so do you observe any ADRs or any side effects giving this 6 months? So we can also be benefit from the knowledge also, ma'am.
Generally, in terms of ADR, we monitor their creatinine and electrolytes, and the biggest ADR that we see is that get a lot of nausea. So nausea is the biggest complication that we see in this patient. So that we have to manage, that leading to poor oral intake. And then problems related to the lines, problem related to infection because the central line is there. So apart from that, per se, imipenem, psilocybin, and sometimes, neurological disturbance, but that we have not seen so commonly. More we have seen local with the PIC line infections and severe nausea and poor oral intake. These are the main areas we have seen.
Okay. And also, as you said, Dr. Alpa, in children, the imipenem can cause CNS side effects. So there we prefer meropenem.
Okay. So his only was that because meropenem we have to be given 3 times, and most of this patient we are managing on OPD basis. That's why we used to select imipenem. But if patients are inpatient, then yeah, meropenem can be a better choice.
We have a question from Dr. Sumer. Dr. Sumer Chaudhary. He's raised his hand. Anyway, I think we are not able to connect to him. Dr. Jaikishan, sir. So you're muted.
We should be taking a shared decision between the patient and the physician that he needs the long administration of the drug through the IV line, and he may need hospitalization. 1, 2, we should not be keeping any drug reserve in a scenario like this where there is a weak regimen, and then we should also be asking for the vigorous physiotherapy and rehabilitation in this patient. Thank you.
Thank you, sir. Are there any other comments?
I think this in this case, we have to see at individual levels what we can do and at programmatic level, because increasingly we have started seeing these kind of patients coming who has taken multiple courses of drugs. There have been delay in getting the LPA reports, and so ineffective regimen get continued for longer period. And so 2 things happen. One is that patient develop worse resistance, and second thing which happens is they get more and more of their lungs compromised. And that is the biggest threat, because once later on, even if we find a good drug combination, but if the lungs are badly destroyed, then there's the issue of penetration of these drugs into bad lung tissue. And then even if we are able to make them culture negative, they become disabled because of the respiratory issues. So many of them become hypoxic, many of them lose the lung function. They are not able to get back to their working and their day-to-day activities. So I think this is very important. I mean, when we discuss such complex cases and we discuss the limited option that we have, but the biggest learning I would say from these cases is how we can prevent them to getting into this stage, as Dr. Rupa Singla had also rightly said. And that's the most important thing, that we should be insistent on getting the DST in time. We should be very vigilant into changing the regimen in time and picking up the defaults and having a mechanism how to trace the defaulters and how to make them stick to the treatment. And I think this is the most important learning from this session, I would say, because there is such a sense of helplessness when the patient comes with a badly destroyed lung and with bad resistant pattern. Very little that we can do for them.
Yeah, I also like to add to Dr. Alpa. You see, many times we have seen that after starting the shorter regimen, the lab has done the test. It has been updated on the NICSHI, but sometimes the DTO and the TA forget to take action on the lab board. And that leads to the delay of say months, 2, 3, 4 months. So also we should make a line listing that whenever the shorter regimen is started, we have to check for the second NLP report and take an early action. Secondly, you see this, if you look at the history of this patient, he has been sort of habitual defaulter. In 2016 also he defaulted after once he improved. So in these cases, we have to make our system stronger, that these defaults are or lost to follow-ups, as we call them now, they are prevented. And if required, they may need hospitalization for long period, at least in the initial intensive phase, so that the bacteria are killed at least in the initial intensive phase, and then it can be taken care of. So, and plus the system should be robust enough to trace these patients. Like in this case, we were told that after the modified longer role regimen, and patient had some leg injury and could not come to the center, the no significant attempts were made to trace the patient. So there also we make our system stronger, that we are able to provide treatment to such cases. We are able to trace them and put them back into the treatment. That's another part of the treatment which is important. Thank you.
Yeah. Thank you, Dr.
So
Singh.
just one
Yeah,
more thing to add is, if I, yeah, so, and the continuation of bedaquiline beyond 6 months. So many times when we have this kind of bad resistant pattern like FQ resistance, and many times as we are following up the patient, they end up developing ADRs to one of the drugs. Commonly we see ADR to linezolid, sometimes cycloserine-induced psychosis, and we have to drop one of the drugs. And that is the time when the right decision to continue bedaquiline beyond 6 months has to be taken. And if that is not taken, that is also one of the big reasons for patient, after getting culture first intensive phase, and then the culture reversion happens because we stop bedaquiline after 6 months and the regimen becomes ineffective.
Even in our institute, we are noticing that as we are having these complicated cases requiring more and more number of drugs from the group C. So these are the cases where we are forced to, and we should continue the bedaquiline or delamanid, whatever the patient is on, or sometimes both of them for longer periods. If we stop them at 6 months and patient is having mainly group C drugs or 1 or 2 from the group A and B, then it will be a poor continuation phase regimen. So in these cases, the DRTB committee should be actively considering continuing the bedaquiline or delamanid, sometime both. So that's a very important point.
Thank you, Dr. Singla. Taking points from what Dr. Alpa, Dr. Singla, Dr. Anand, Dr. Radha Munje, Dr. Jayakishan, all the senior doctors have, raised the same point that we have to take care right at the beginning, rather than waiting for the patient to, come to a stage where you don't have much treatment to give. So if we go, what take-home message I'll take from this case is that right in the beginning, all the DTOs should ensure that a universal DST for the patients is done. Every patient should undergo CBNAT. There has to be a line listing. What happens in the field is the field workers, that is our STLS and DRTB supervisors, they keep shifting duties on each other. As soon as they suspect DRTB, or if a patient is diagnosed as DRTB, the other field staff, they stop seeing this patient and they shift all duties to DRTB supervisor, who has to look after the whole district. So it has to be made very clear to STLS that they have to get the universal DST done. They have to get the LPAs done. They have to get the second line LPA done, maintain the line list, put them in a register and inform the DTO, what is happening with the patient, number one. Number two, the DTO should be in constant touch with his DRTB committee, the nodal DRTB committee, because as per guideline also, all DRTB patients are to be seen by the DTO at least once a month. I know it's not possible. There's a lot of work on DTOs, but then somebody has to see, then some representative of the DTO has to see the patients and, be in touch with nodal DRTB center for changing the treatment or giving him the appropriate treatment. The second point which everybody stressed on was contact tracing. That contact tracing was not done properly in this case. The daughter also had, TB, and we don't know if she had DRTB. Then during shorter regimen, second LPA was not done. Timely default retrievals were not done. Why should we wait for a patient to default? The action should have been taken when patient was interrupting. So, these things at the field level have to be seen, that as soon as a patient interrupts, they should be called back and put on treatment. There should be a mechanism where automatically this information should reach the DTO that there's a certain patient who is not taking his treatment properly, and they should be counseled by the whole team. And when coming to the treatment difficulties of treatment, which you've just said, the cost of imipenem is a very big issue, which I think we have to take up with with the ministry to have some funds for such kind of patients where exceptionally we can provide for these medicine wherever possible. So I hope I have not missed any point. Dr. Alpa, Dr. Singla, would you like to add anything?
Yeah, you are correct, ma'am. There
Yeah.
is no space for loss to follow up. Actually, the patient become resistant or become XGR and PXGR only when we fail to trace them when they stop treatment. So this is a take-home message by this unique case from my side.
Thank you, sir. So I think the biggest message from this case is prevent defaults, take action as soon as patient interrupts treatment. And of course, the early LPA, the first line and second line LPA as soon as possible. So with this, I would now request Dr. Ashok Bharadwaj, sir, who is the chairperson for the National Task Force, to give his comments and vote of time. Sir, you are muted, Bharadwaj, sir. Sir, you're muted.
Now,
we can hear you now, sir.
The host was not unmuting me. So thank you, Nita. Whatever I was to say, you have explained it in detail. So the fault is at the field level. I will not say the fault. It is maybe limitation, maybe their deficiency, but the action has to be taken at the field level, because when the case came to their institution, they have done the best what they could ever do it. So here on this platform, I will request the State Task Force Chairperson, Dr. Jaikishan, please, no, it will not lead us anywhere, but we will know the history. Please ask the concerned officer and the DTO Karnal to investigate this case so that we may know what happened to this case, why this case was not, this case was lost to follow up 3 times. So why it was not retrieved and put on treatment or initially referred to the medical college. So I thank Anita for this wonderful case, Dr. Rupak and Dr. Alpa for their wonderful the discussion focused on this case, as well as a general discussion for everybody. So I thank Dr. Anand Agarwal for bringing this case for national discussion and which everybody was benefited. So thank you, Nita. Thank you for giving me a chance. So I reiterate that Dr. Jaikishan, your responsibility is to please take us to the root cause of this case, why this case has happened to this condition. So thank you very much. Thank you.
Thank you.
You are muted, Dr. Nita.
Yeah, there is a feedback form in your chat. Kindly fill the feedback for us to improve. And also request all these states to start their own clinics, these difficult to treat TB clinics, so that more and more such cases can be discussed and the benefit goes to the patient as well as to the people who are attending. So with this, I would like to thank you all and hope to see you in the next clinic. Thank you so much.
Thank you.